Today, December 8th, testicular cancer with Mary Dunn, MSN, RN, OCN, NPC. So let me just let you know a little bit about Mary. Mary Dunn is a certified adult nurse practitioner who joined the GU Oncology team in 2010. She works in a multidisciplinary role providing care to urology and medical oncology patients with genitourinary malignancies. Her clinical interests include survivorship and palliative care. Mary is the director of the Testicular Cancer Survivorship Program and the co-director of the von Hippel-Lindau Comprehensive Clinical Care Center. She is involved with several professional organizations, including serving on the board of the NC Triangle Oncology Nursing Society, co-founder and board member of the NC Triangle chapter of the Bladder Cancer Advocacy Network, and is involved on a national level with the American Urological Association and the Bladder Cancer Advocacy Network. She also serves as adjunct faculty in the UNC School of Nursing and precepts nurse practitioner students. Mary received her bachelor's in science and nursing from the University of Virginia and her master's of science in nursing from Duke University. Mary Dunn, welcome. We're really glad to have you here today.
Hey, Tim. Thanks so much for having me.
Oh my gosh, with all that you're doing, thank you for taking time out to present on this very important topic. We always do a softball at the beginning, and everything's anonymous with Poll Everywhere, so I'm just showing you a slide of what's about to pop up in Poll Everywhere. Testicular cancer primarily develops in which type of cell? Would that be the latex cells, the Sertoli cells, or germ cells? And so you can put A, B, or C, and that should pop up in just a minute. And while we're doing that, I'll say this activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William A. Wood, MD, MPH, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Mary Dunn, MSN, NPC, OCN, RN has no relevant financial relationships with commercial interests as defined by the ACCME. Whew, got it. All right. And Mary, what's one thing we might know about you outside of your professional bio there?
Tim, I think one of the strangest things that people would never guess about me is that I am afraid of penguins.
Afraid of penguins.
I am afraid of penguins. Mm-hmm.
And so the good news is, by and large, that's not we hope that's not a fear you have to face on a daily basis. And there, it appears there is actually a name for that, although I don't think I can pronounce it.
It's completely irrational, but you're right. I'm not going to run into any penguins around here, thankfully.
All right. Well, let's take a look at that poll, and that is now open, and so we'll encourage you to go ahead and again, everything's anonymous here. Take about 15 seconds, if you would please, to go ahead and make what you think is the correct selection for that first question. This is the softball. They get a little harder after this, so enjoy this one. Mary, looks like we're really favoring germ cells. C is the answer. How are they doing?
Perfect. That's it.
Great, great. All right. Well, testicular cancer management and post-treatment survivorship. We'll turn it over to you. Thank you so much.
Great. Thanks, Tim. And thanks, everyone, again, for taking time out of your day to join me. Testicular cancer is one of my favorite things to talk about, and we could have hours-long discussions about all of the things related to testicular cancer, but given our limited time, this talk is really going to be kind of a testicular cancer 101 general overview. So hopefully you'll take away from the talk kind of diagnosis to treatment to post-treatment survivorship is kind of the goal here. So next slide. And these are our objectives. So to identify treatment options for testicular cancer depending on subtype and stage, to discuss common treatment-related side effects and describe at least 3 challenges that patients may face in the post-treatment survivorship phase. Next slide. Okay, so I'd like to kind of start with the definition, and of course this is very basic, but testicular cancer is a disease in which malignant cells arise in the testicle. And the vast majority, so roughly 90% of testicular cancers develop in the germ cells, and germ cells make up the sperm. Next slide. Just a little quick anatomy lesson. So the testicles are part of the male reproductive system, and they produce testosterone and sperm. I'm not going to kind of go through every little step of the anatomy, but if we go to the next slide, you can see kind of a nice picture. There we go. So the testicle with the epididymis, the vas, you can see it. The testicle sits down there in the scrotum. Next slide. So how common is testicular cancer? As many of you may know, it's actually not that common overall, but it's the most common cancer in boys and men ages 15 to 35. So this year, I think we're still in 2021, aren't we? I have no concept of time anymore. It's estimated that 9,470 new cases will be diagnosed and 440 will die from their disease. The lifetime risk is 1 in 250, and the risk of death is 1 in 5,000. As you can see, the average age of diagnosis is relatively young as compared to other patients who have cancer, so 33. 6% of cases occur in children and teenagers, and roughly 8% of cases occur in men over 55. So again, testicular cancer as a whole, as we compare to other cancers, is pretty rare. So it only accounts for roughly 1% of all male cancers, but it is the most common cancer diagnosed in boys and men ages 15 to 35. Next slide. So as you can see from this slide, the vast majority of testicular cancers, when they're diagnosed, are localized. In other words, they're confined to the testicle and have not spread outside of the testicle. And as you can see, sorry, I'm trying to move my thing so I can see. The 5-year relative survival rate, even for metastatic or advanced testicular cancers, is quite high. Next slide. So what are some risk factors for developing testicular cancer? So undescended testicles, so 7 to 10% of patients with testicular cancer have had an undescended testicle. There is some link to family history, so father or brother who had testicular cancer, but that only accounts for a small number of testicular cancer cases. HIV, personal history, so men who have already had testicular cancer do have a risk of developing another tumor, another primary tumor in their remaining testicle. So that's why patient education is hugely important even after they have their orchiectomy, which we'll talk about, to make sure they're still doing monthly self-exams of their remaining testicle because of that risk. White men are more likely to be diagnosed, and men who have fertility concerns are more likely than the general population to develop testicular cancer. Next slide. Okay, so how does one present with testicular cancer? Most of the time, it's a painless mass or lump in the testicle. Sometimes we'll see men complaining of heaviness or aching in their lower abdomen or scrotum. Contrary to popular belief, a baseball to the groin area does not actually cause testicular cancer. It's usually an incidental finding if men have injuries down there and they come in, get an ultrasound, and you say, oh, oops, and you also have this tumor. So trauma does not actually cause this. Sometimes men will present with gynecomastia or breast tenderness, which is caused by elevated levels of HCG. And for men who present with advanced disease, they might have low back pain because of tumors in the retroperitoneum, shortness of breath or chest pain or cough if they have large and multiple pulmonary nodules, abdominal pain, etc. Next slide, please. Thank you. So how do we kind of work up testicular cancer? So physical exam is hugely important for these men. So obviously doing a testicular exam. Testicular tumors feel like a tumor, like one would think a tumor would feel like they are hard and they are firm inside the testicle. And also doing a complete physical exam as well, and not just the testicles. So scrotal ultrasound is highly sensitive for being able to distinguish what's a tumor and what's not, especially when combined with the physical exam. We do get tumor markers, which we'll talk about what those look like. So those are blood tests, and we get them before orchiectomy. So orchiectomy is surgical removal of the testicle, which is the primary treatment for testicular cancer. And then we get them after orchiectomy, and there should be a predictable decline after orchiectomy, which we'll talk about. post-chemo, so for men who have more advanced disease, if they get systemic chemotherapy or radiation, sometimes we can see a therapeutic lag in their tumor marker response if their tumor markers were elevated at the time of diagnosis. And we always like to get a baseline chest x-ray to make sure there's no concern for pulmonary nodules. Next slide. Okay, so here's our tumor marker slide. So there are 3 serum tumor markers that we evaluate for men who have testicular cancer. So AFP, beta HCG, and LDH. And what I've done here is I've listed the subtypes of testicular cancer that are kind of associated with these tumor markers and how long it takes the tumor markers to kind of normalize after orchiectomy. AFP and beta HCG are pretty specific, but LDH is not as specific as those two. Next slide, please. Okay, so the vast majority, as we talked about in the beginning, of testicular tumors are germ cell tumors. A small percentage are sex cord or stromal tumors, and I'm not going to talk about management of those in this lecture, so we're kind of focusing on the germ cell tumors. And of germ cell tumors, we further categorize that into 2 different categories. So either seminoma or non-seminoma, and then there's multiple subtypes under non-seminoma. So it's really important to have a good understanding of what that pathology report means, because that helps us determine next steps for treatment following their orchiectomy. Next slide, please. Thank you. So this slide just kind of goes through the non-seminomatous germ cell tumors versus the seminoma. So there are mixed tumors. So sometimes we'll see tumors that are a mixture of seminoma and non-seminoma, and we treat those like non-seminoma. This just kind of goes through the different subtypes and what they look like under the microscope in case you're interested in that. And it also shows what hormones or tumor markers that they secrete. And I think I have another slide that's a little bit more organized than this one. Next slide, please. Yeah, here we go. So I like this slide because it kind of goes through the different subtypes of the non-seminomatous germ cell tumors and then seminoma. And here you can see the most common age at which these subtypes are diagnosed, what tumor markers that we could expect them to make or definitely not make, and if they are sensitive or resistant to certain treatments. So I will point out on this slide that seminomas are sensitive to radiation, and that's important as we talk about different treatment options. All right, next slide. Thank you. So radical orchiectomy is standard of care for initial treatment for testicular cancer. So we use an inguinal approach and really try to avoid seeding the scrotum and disrupting the lymphatics. So we don't biopsy these tumors ahead of time because there is a chance of seeding and increasing the chance of a local recurrence. So testicular tumors should not be biopsied ahead of time. If there is a high suspicion for cancer, it should just be removed. It's a relatively quick operation, so usually takes about an hour, and sometimes our patients will go home the same day. Sometimes they'll stay overnight, kind of depending on their clinical circumstances. Next slide. Thank you. So after orchiectomy, so of course, as I mentioned, you get their serum tumor markers preoperatively, and then post-op, you need to wait kind of a specified amount of time to re-evaluate them, especially if they were abnormal prior to orchiectomy, because you want to make sure you give those tumor markers time to do what they're going to do if they're going to decline. So it takes 1 to 2 weeks for HCG, 3 weeks for LDH, and 5 weeks for AFP. So the S stage, and we'll talk about staging, is used to determine the nadir value of the post-orchiectomy markers. So you don't determine the S stage on the pre-orchiectomy markers, just for the post. We like to do CT abdomen pelvis. Sometimes this is done before surgery, sometimes after. It's really depending on how quickly we can take someone to the operating room. So we like to do these operations as soon as possible. So sometimes that doesn't allow for time to do the CT of the abdomen and pelvis prior to, but that's a really important diagnostic that we need to do to see the extent of the cancer. So something I like to point out about CT scans is that a CT can't differentiate between what's cancer, what might be teratoma, what might be necrosis or fibrosis. So abdominal CT has a 30% false negative rate, just as a little tidbit there. Next slide. Thank you. So this is a horribly small slide. I'm really sorry about that. But so when we're staging cancers, we're talking about what is the extent of the cancer. So this is the TNM, as I'm sure many of you are familiar with. So the T is the primary tumor. So what does that testicular tumor look like under the microscope? How invasive is it? And then there's clinical nodes. So in other words, are there any concerning nodes on imaging? And then pathologic staging of lymph nodes if a patient has an RPLND. And then M for distant metastatic disease. And then S is for the serum tumor marker staging. So you can, I'm not going to go through every single line of this because that would take the rest of the lecture, but how we treat men after their orchiectomies is highly dependent on their staging. Next slide. Okay, so for men who have advanced disease, we do put them into these risk categories because that does help determine if they are candidates for chemotherapy. It helps us determine how many cycles of chemotherapy they'll get for the non-seminoma germ cell tumor patients. And also kind of helps us determine outcomes. So this is just another factor to consider if you have a patient who has advanced disease. Next slide, please. Thank you. So if testicular cancer is going to metastasize, the most common place we'll see that happen is the retroperitoneal lymph node. So that's why that getting that staging CT scan is really important so we can make sure there's no nodes. Oftentimes it's a relatively predictable pattern where they're going to spread. So if the patient has a right-sided tumor, we most often see them in the intra-caval region. And if a patient has a left-sided tumor, we might often see them lymph nodes in the left periaortic region. Next slide. So rarely do we see inguinal nodes, but just kind of put that up there as an FYI that's a thing that we can see, but that's not as common as the retroperitoneal and pelvic lymph nodes that we see. So testicular cancer can go beyond the lymph nodes. So the most to least common as far as distant metastatic disease outside of lymph nodes are lung. Seen some really extraordinary pulmonary metastases. Liver, brain, bone, kidney, etc. These things are, especially kidney, adrenal, GI, spleen, those things are incredibly rare as far as sites of metastases, but I like to include everything just so you have an idea of where this could potentially spread. Next slide. This is just a picture. It's taken me a long time. I've been doing this for 12 years to really get a good sense of where these lymph nodes land on the CT scan because sometimes they can be very, very subtle, but this is just a diagram of the retroperitoneum and the different landing zones for some of the lymph nodes. So it can take a while to really feel comfortable looking at these CT scans, but every new patient who we see, we review their images and tumor boards so that we can all be on the same page about whether or not we have any concerns about enlarged lymph nodes in the retroperitoneum. Next slide, please. Okay, so after orchiectomy, what treatment do folks get? So again, that depends on staging. So we can either, they might get chemotherapy, they might get radiation therapy, they might have surgery with a retroperitoneal lymph node dissection, and that creepy picture of the camera just represents surveillance. And my other option there was a creepy guy with binoculars, so I went with the creepy surveillance camera. Next slide. Okay, so primary chemotherapy. So what do we know about chemotherapy for men who have testicular cancer? So I'm going to talk about the different types of chemo, and then I have some slides that go through the different subtypes and stages of testicular cancer, and you can see who may be eligible for this based on their subtype and their staging. So cisplatin is the most effective agent against germ cell tumors. And one of the most common regimens that we use is called BEP, and that's short for bleomycin, etoposide, and cisplatin. If a patient is not eligible to get bleomycin, then we can do etoposide and cisplatin. Bleomycin comes with pulmonary toxicity, so we do pulmonary function tests prior to bleomycin. And if a patient has poor pulmonary function, then we have to make the decision to not do the bleo and do the etoposide and cisplatin alone. The pneumonitis and pulmonary fibrosis with the bleo is not a terribly common thing that happens, but we worry about this more in patients who are former smokers or actively smoking. So another good tidbit of education is to try and do tobacco cessation counseling if your patients are actively using tobacco products. And then commonly with etoposide, we'll see things like myelosuppression. So of course we watch people's CBCs like a hawk, alopecia and mucositis. And then with cisplatin, platinum-based chemotherapy, we worry about things like nephrotoxicity. So of course, keeping a close eye on their creatinine clearance, neurotoxicity, ototoxicity. So we want to make sure we have a good understanding of people's baseline hearing function and nausea and vomiting. And then carboplatin is another platinum chemotherapy that can be used for pure seminoma, one cycle, but a lot of times we do surveillance for those patients. So I think in the coming slides I have an algorithm that shows which patients are eligible for which therapies. So let's go on to the next slide, please. So other chemotherapy, so that's the primary chemotherapy. So other chemotherapies are indicated in the salvage setting. So this might be patients who didn't respond to their primary chemotherapy. Either they're progressing on the chemo that they're currently getting or they've relapsed after primary chemo. And I just listed the regimen that we use. So these are given in the inpatient setting. So I should mention that regimens like BEP and EP are given in the outpatient setting. But the salvage chemotherapies are given inpatient because they have to have Mesna running with them 24 hours. And it's usually a 5 to 6 day admission. And the complete response with these is roughly 50%. Very rarely do we have to use high dose chemotherapy and bone marrow transplant. I think in all of my years of doing this, I've had 2 or 3 patients who have needed to have a bone marrow transplant. Of course, my other teammates have other patients, but in my kind of personal patient population, there have been 2 or 3. We do this in the context of poor prognosis or patients who don't respond to or don't or who progress after salvage options. So they'll get auto transplant. I am not a bone marrow transplant expert by any stretch of the imagination. And 10 to 20% of those patients will achieve a durable remission. I'm thinking of one of my patients now who's 2.5 years out from his bone marrow transplant and is doing absolutely beautifully, and very few complications during transplant and very few complications post-transplant. So it's nice to see those success stories. Next slide, please. And then full disclosure, I'm not a radiation oncology expert. I do urology and medical oncology, but I'd like to obviously include all of the different treatment options. So external beam radiation therapy is used to treat stage 1, 2A, or 2B pure seminoma. Toxicities can include things like nausea, vomiting. The most common things that men will tell me is that they just feel tired. If they have any contraindications to radiation therapy, so for example, if for whatever reason they've had prior abdominal radiation or IBS, then can consider surveillance in these people if we're concerned about toxicities. And then retroperitoneal lymph node dissection is a big old belly surgery. But my surgeons who do this will try to do this laparoscopically to avoid kind of that very large midline abdominal incision. So they'll try to do some nerve sparing if they can to help kind of preserve ejaculatory function. However, we never compromise cancer control in order to do that. So that's just something that we have to talk to our patients about prior to surgery, is that they might not have any ejaculate after this surgery because of how the nerves have to be, might not be spared. Next slide. Thank you. Okay. So in talking about the specific subtypes of testicular cancer, so pure seminoma, for stage 1A or 1B, if it's a T1 or T2 tumor, we'll do a lot of observation. For surveillance and observation, one of the most important factors is does your patient have the social structure and social support in order to stick to a surveillance schedule, because it's intense, especially the first year. They have to come in for very frequent visits. So sometimes even if a patient is a candidate for observation or surveillance, it's not always the best choice if they're going to have difficulty getting to their appointments, or if there's any concern that they just might not be able to stick to that schedule. Then we can consider doing something like 1 dose of carboplatin or radiation therapy. For pure seminoma, go one back to, there you go. For stage 2A or 2B, we can do radiation or chemotherapy. And then patients who have stage 2C or stage 3, we recommend chemotherapy. And again, the number of cycles of chemotherapy depends on what their risk category is. So that's why putting people into those risk categories is important, so we make sure we give them the proper treatment. All right, Tim, ready for you now. Thank you. So non-seminomatous germ cell tumors that are stage 1 with no risk factors, we do a ton of surveillance for these patients because the other options are RPL&D or chemo. And those do come with potential consequences and might lead to overtreatment. So the risk factors that we have to consider when we're looking at how to follow folks with stage 1 are things like lymphovascular invasion or spermatic cord invasion are the major risk factors for potentially having a higher risk of recurrence. But still, we can do surveillance for those folks. They just have to be appropriate candidates for it. And then if a patient with stage 1 does have an RPL&D, if they don't have any positive lymph nodes, then they go on to surveillance. If they're in 1 or in 2, then we could either do observation or give them some chemotherapy. If they have if they're in 3, then we give those patients chemotherapy. And then, one more back, sorry. I know these are busy slides. If they're stage 2C or 3, then you can see the chemotherapy options there. And then depending on their response to chemotherapy, they can either have go on to an RPL&D, and if they don't respond well at all to chemo, then we have to consider salvage therapy, like different chemotherapy that we talked about in previous slides. Next slide. Okay. So as you can see from this slide, there is really, really high 5-year overall survival rates for all stages of testis cancer. So if you see there on the far left column, you see stages 1 through 3. For those of you who are familiar with other cancers, you might be asking yourself, where's the stage 4? There's no such thing as a stage 4 testicular cancer because it's curable at every stage. So that's just another little nugget. So as you can see, stage 1, both seminoma and non-seminoma, highly curable, highly treatable. And even the more advanced stages, good, intermediate, and poor risk, can also have good outcomes. Next slide. Oh, it's question time. Which of the following is a treatment option for good risk stage 2C non-seminomatous germ cell tumors? So let me give you a little hint. So this is a more advanced stage. So when we're thinking about patients who have more advanced non-seminomatous germ cell tumor, what do you think the answer would be there?
Right. Thank you. And if you take about 12 more seconds or so, and again, best guess is fine, all anonymous. All right. Mary, how are they doing?
That it is answer D, solid work, BEP times 3 cycles. Excellent. Okay, so I have several slides about treatment complications, and these slides are dense for many reasons, but there could certainly be potential treatment complications that are either immediate or long-term, which is why making sure patients understand the importance of their post-treatment surveillance visit is hugely important because they can have long-term complications from their treatment. So I'm not going to go into all of these in major detail, but I do want to highlight some that are pretty common and important and things that we should talk to our patients about. And I think you have access to the handout, so you'll have all of the information written down. So sometimes we'll see men who end up being hypogonadal, and typically this is not caused by a unilateral orchiectomy alone, but for men who do have bilateral orchiectomies for 2 primary tumors, they have to go on testosterone replacement therapy. So that's really important. I manage that for these patients because I do urology as well, so that's something that I typically manage for them. One of the most important education points is consider if men are going to have chemotherapy or RPL&D, and even men who have orchiectomy alone sometimes choose to do sperm banking. It's hugely important. Remember, a lot of these patients are young. Thankfully, at UNC, this is a very well-oiled machine. We have a wonderful AYA program who helps us with this, and our fertility colleagues to make sure this gets done quickly and in an efficient manner. So chemotherapy can affect spermatogenesis. RPL&D can cause infertility because it can result in retrograde ejaculation. The same thing with radiation, although less likely. It's not to say that men will be infertile forever, because spermatogenesis can recover over time, but it's not a guarantee. So we always recommend sperm banking when it's possible. Next slide. Thank you. So one of the more common treatment complications that I see for men who've had cisplatin-based chemotherapy is neuropathy. And we typically see this kind of in the fingertips and in the toes. There's not, unfortunately, a ton of great management options for this. There are some medical management, so drugs like pregabalin, but those do come with side effects, and sometimes they just don't work. So making sure we're educating our patients about protecting their hands and feet, wearing loose clothing and good, solid, supportive shoes. Everyone has fatigue, whether it's due to radiation, chemotherapy, or a combination. Also treating underlying causes that might not be related to their cancer, so depression, anxiety, thyroid stuff, making sure they're getting good sleep, so educating patients about good sleep hygiene. And the treatment that has the most data to support its use as far as being the best treatment for fatigue is actually exercise. And patients look at me like I'm completely insane when I say you will feel better if you exercise, because all they want to do is like hang out on the couch because they're exhausted. But just encouraging them to try and be physically active. No one needs to be running a marathon. Just a brief walk, sometimes just for 10 minutes a day, can help them feel better and combat that fatigue. And anxiety and depression, as a society, we don't do a great job of talking to young men about their mental health. I won't get on that soapbox for too long today, but it is hugely important. We should be asking them these questions. How are you doing with the emotional aspect of this cancer experience? Because we move very quickly with these patients. If there's a suspicion for diagnosis, because if there is a delay in care, it can affect their outcomes. So we move very quickly and sometimes don't address the emotional and psychological aspect of their cancer experience. So anxiety and or depression can be caused by their cancer experience, or it could predate their cancer diagnosis. We have wonderful mental health providers on our team at UNC that can help with not only talk therapy, but medical management as necessary, and then encouraging participation in support groups if that's something that they think would be helpful. Next slide. So these are things that can happen with cisplatin-based chemotherapy that we touched on briefly. So ototoxicity, nephrotoxicity. We talked about the pulmonary toxicity that's related to bleomycin, and I cannot emphasize the importance enough of smoking cessation and making sure that pulmonary function tests are done prior to bleomycin, during chemo, so prior to each cycle, and then as needed if there's any concern for pulmonary toxicity. And then sometimes men have chronic pain related to postoperative complications. If they have an RPL&D, it's a big surgery, but chronic pain is pretty rare for these folks. Next slide. So this is a very dense slide, and I apologize for that, and I won't read it word for word, but there can be cardiovascular toxicities due to chemotherapy. And I've actually seen this a handful of times where men who were treated 20, 30 years ago and who are in impeccable physical condition have actually had heart attacks, and the only reason that we think that they did is because of their chemotherapy exposure. So this is part of the reason why everyone needs to have a primary care provider once they're officially discharged from their cancer surveillance, so that primary care can kind of be on the lookout for any concerns and be monitoring things like blood pressure and lipids, which can all be tied into cardiovascular toxicity long-term from chemotherapy. Next slide. And then anyone who gets chemotherapy is at a risk for developing a second cancer. I have seen this happen once, and I will never forget it because it was horrifying, but I had a patient who had chemotherapy who was doing fine. And he came in for his regular visit with me, and I always get at least an every 6-month CBC on patients who have had chemotherapy. And his white count was nearly non-existent. He ended up being diagnosed with acute leukemia. It's rare, it's very rare, but it's also something to keep in mind that patients who've had chemotherapy, we need to make sure if they're really far out that they're getting at least an annual CBC. Next slide. All right, now I know everyone's going to get this one right. So you are counseling a patient about toxicity associated with bleomycin. What side effect is unique to this chemotherapy agent used for testis cancer treatment?
And please take just a couple more seconds. Mary, everyone seems sold on B. Is that correct?
That's perfect. Excellent work, y'all. All right. So what happens for patients after treatment? So after they complete their treatment, they transition into a surveillance program. So we use guidelines from the NCCN to help us guide how often we see these patients and what diagnostics we're doing. Most patients are followed by their primary oncology provider. However, this can be challenging because post-treatment survivors can get lost in the shuffle of a busy practice, and they're being mixed in with people who are actively getting chemotherapy while they're there for surveillance. And it can also be a challenge if they've had chemo and surgery and radiation, like who actually owns their care. So we're going to talk about that a little bit. Next slide. So this is where models of survivorship care come in. So there's lots of different models if you look at the literature, and there's no one best way to do this, but it is important whether you're in a community setting or academic medicine to really think about how your team is providing post-treatment survivorship care. So there's a shared care model where patients will see their oncology provider some and then see their primary care provider some. The oncology provider, delivers the cancer therapy, keeps the primary care informed, does the long-term follow-up for cancer recurrence, but then primary care does basically everything else. So make sure that they're getting, their head-to-toe physical exam and screening for other health problems. So that's one model. Next slide. And then a lot of different structures happen in academic medical centers. So there can be a disease-specific cancer survivor program. There could be comprehensive survivorship programs where it's like an actual survivorship clinic with a bunch of different people. So it can be oncology, it can be dietitian, it can be our pharmacy colleagues, it can be all kinds of people like in that survivorship clinic. And then what we do with our group is I lead our nurse practitioner survivor clinic. So these are patients who get transitioned into my clinic following their active treatment. and I take over their surveillance. Of course, if they don't want to do that, of course, we don't force people to do anything they don't want to do if they're more comfortable with their primary oncology provider. But it's part of what we do at UNC. Next slide. So we don't really know which model of survivorship care translates into improved patient outcomes. There's kind of always going to be a debate about who should be responsible for providing this care, and it really depends on where your setting is, what your resources are, and the specific type of cancer and treatment that patients have had. Next slide. So what are the different components to survivorship care? So there's coordination, which there can be a lot of different components of coordination. So making sure people are getting, making sure we are communicating with our patients effectively and with the other members of their treatment team, including primary care, and that we're giving them their care plans, which we'll talk about. Prevention and detection, so promoting healthy behaviors and recommending age-appropriate screening procedures. So for testicular cancer patients, many of whom are very young, they don't need screening things like colonoscopies and that kind of stuff yet. But obviously our patients who are older do. Doing the surveillance part, so all of the diagnostics and assessing for late effects from their treatment, and then doing the interventions for the side effects of their cancer and treatment. So whether that encompasses everything, physical, psychological, social, and spiritual. So it's pretty dense. Next slide. So a survivorship care plan is an actual document, and I have a picture of one that I'll show you. So it incorporates their treatment summary, so what their treatment was, who provided that treatment. It has a copy of the NCCN guidelines and what the follow-up schedule will be and what's done at every visit. In general information about wellness, exercise, nutrition. It lists possible late effects of cancer and cancer treatment and support services and resources for patients. Next slide. So for testicular cancer, their treatment summary generally looks like who was their surgeon, what was their pathology from their surgery, orchiectomy, and RPL&D if they had one. If they got chemotherapy, who's their medical oncologist, what type of chemo did they get, and if they had radiation, who's their radiation oncologist, and what was the dose of their radiation. Next slide. So why does survivorship care matter for this patient population? There's lots of potential long-term treatment-related toxicities that they may face related to their sexual health, chemotherapy-induced toxicities that we've talked about, mental health that we've touched on as well, monitoring for secondary malignancies, and they have extensive follow-up schedules. The first couple of years for these patients, they're coming in a lot, sometimes every 2 to 3 months. So it matters for many reasons. Next slide. So our clinic was established in 2008, and I kind of took it over in 2011. It's a monthly clinic that's led by me. Of course, if they can't come to that specific clinic, I have 4 clinics a week, so I'll see them anytime, anywhere. Next slide. And they transition to me once they're done with their definitive treatment. When that happens depends on their provider. So it's usually after the first surveillance visit, following chemo or surgery or radiation, they get transferred to me. I give them their care plan if they don't already have it, do all the things that are normally done, right? History, physical, review their diagnostics, side effect management, discussing health maintenance things. And a lot of what we do is assessing worry and fear related to uncertainty, because these are important things to talk about. Next slide. Lots of challenges. I could have an entire lecture on all of the challenges that we face with this patient population. So sometimes these guys move around a lot. So I have a lot of patients who are active military, graduating from college, getting married, relocating. I have society there because, again, I think society as a whole, we do a bad job of allowing men to have difficult feelings as it's related to their cancer experience. The toxicities, fear of recurrence, financial barriers. I put parents on there because sometimes my younger patients who are in their 20s, I've seen them butt heads with their parents because their parents want to be parents during this, right? And they come with them to their appointments, and they're a great resource, but sometimes my patients get annoyed with their parents. Don't get annoyed with your parents. Next slide. Thank you. So the benefits of this clinic, so a dedicated clinic are, I'm their person, so it's consistent care. This is one of my areas of expertise. I can manage their late and long-term side effects. We do a lot of counseling. I do a lot of coordination of care with their primary care providers. I make sure everyone has a primary care provider, and it's continuity, which I think is really important in the post-treatment surveillance setting, because sometimes people worry, right? They go from seeing us very often during active treatment to not seeing us as frequently. It frees up my physician colleagues to see new patients or patients who are actively being treated. There's an oncologist shortage, so that it helps when there are advanced practice providers who can help meet these needs, and it's sustainable and cost effective. Next slide. Okay, testicular cancer survivors may have unique needs as compared to pediatric patients and older adults. What are some challenges that they may face? Guys are knocking it out of the park again. Thank you. You're right. The correct answer is D, all of those things. Thank you. Okay, so in summary, testicular cancer has a low overall incidence, so it's pretty rare, but it is the most common cancer in men, boys/men aged 15 to 35, highly treatable and highly curable. However, a delay in treatment can decrease overall survival, so that's why we move very quickly with these patients when they're diagnosed. Treatment options vary greatly depending on their subtype and stage, so either orchiectomy for everyone, and then after that, either surveillance, chemotherapy, RPL&D, or radiation, again, depending on those things. Toxicities can be immediate or long-term, and post-treatment surveillance care should include all aspects of components of survivorship care. And I think I lied to you. I didn't have a picture of the care plan. I'm sorry about that. Next slide. So I do want to highlight very quickly one of my favorite resources is the Raleigh Testicular Cancer Foundation, which was founded by Matt Cross, who is a testicular cancer survivor. They are the only organization in our area dedicated to helping men with testis cancer, whether it's folks who are actively undergoing treatment or are in post-treatment survivorship. His contact information is there. You are free to give it to your patients. He is a wonderful human being and always willing to talk to patients. So check them out. Their website is very clever. Checkyouracorns.org. It's Raleigh, City of Oaks. It's pretty clever. Next slide. These are additional patient resources. And I think, again, you'll have access to the slides, so I won't go through all of them. And then next slide. Some references. Next slide, I think, is also references. And the next slide, I think, is just a thank you. Yeah, thanks. That was really fast. I'm so sorry.
No, that was a tremendous amount of information, extremely well presented. I have loads of questions, so I want to encourage our audience to ask lots of questions so that I don't monopolize the rest of the lecture. So please, poll everywhere is open for your questions. I'll be watching for those off to the side, and while we're waiting, I jotted down a few. So there, about 2 years ago, I saw some research come out from, I believe it was Dr. Robert Huddard, about potentially decreasing the level of chemotherapy for treating testicular cancer. And that, do you have any information about that?
Yeah, that's not something that we've incorporated into clinical practice. So that might be not necessarily reducing the amount of cycles that we give to patients, especially those with advanced disease, but there's always been a concern for in early stage testicular cancer that we're over-treating people. So that's why we tend to lean more towards surveillance and less towards like that one cycle of carboplatin or the one cycle of BEP, because even one cycle of those things can potentially have long-term consequences. So I'm wondering if that's what that messaging was in that research, is to surveillance instead of chemo.
Gotcha. Thank you. And I will keep checking here, waiting for to see if we have questions coming in. And while we're waiting, I'll ask another one. You mentioned peripheral neuropathy for patients receiving cisplatin. A quick plug for one of our 2022 lectures will actually be with Taxol for treating breast cancer, reducing peripheral neuropathy with cryotherapy boots and gloves for those patients. And there's been some really interesting study done there. And I wonder, do you know, is there anything that translates into preventing peripheral neuropathy with testicular cancer patients in terms of cryotherapy boots and gloves? It's not Taxol, it's cisplatin, but I didn't know if there was anything that had been done with that.
You know, Tim, off the top of my head, I don't, but that is really fascinating because this can be a debilitating side effect. I mean, thankfully, most of my patients, if they experience it, it's relatively mild. But if it's moderate or severe, it can really impact people's quality of life. And it's one of those things where even once the chemotherapy is complete, it can linger for what seems like forever. I mean, I have patients who had chemotherapy several years ago who still have some degree of that peripheral neuropathy. So yeah, that's actually really fascinating. I need to put that on my calendar so I can learn more about it. Thanks for the plug.
Absolutely, and we will. We're still identifying the presenter for that, but we will specifically ask that person if there's anything she or he can do to address some cisplatin toxicities in addition to Taxol.
That's great.
All right, we do have a question that just came in. Let me put that up on the screen. During active treatment, we tend to focus on immediate side effects related to treatment, i.e. chemo side effects. What survivorship pearls should nurses, I'm assuming there's a little more, know about? We'll interject that or be aware of.
I think one of the most important takeaways for this patient population is, and again, this is a bit of a soapbox of mine, is the uncertainty related to recurrence. It's real for these patients, and we just don't always do a good job of checking in. The question that I ask is simple. How are you doing with the emotional aspect of your cancer experience? I try not to call it a journey because some people don't like the word journey, so I call it their cancer experience. A lot of patients are fine in that regard, but some really aren't. So making sure that, because you're right, like during treatment, we focus on the poor appetite, and they focus on, the nausea and the vomiting and all of those things. But patients carry a lot of uncertainty with this diagnosis. So just making sure we are touching base with them about their emotional well-being, their psychological well-being, making sure they feel like they have a good support structure kind of outside of the four walls with us, and making sure that if you are addressing that you know where your resources are, right? Like, so fortunate here at the main campus to have mental health providers, palliative care providers, folks who can help in a more extensive way than I can. So if you're going to initiate the discussion, make sure you know where to steer your patients and other experts who can help them with the uncertainty and anxiety. I hope that helps. Thank you for asking.
Thanks to our listener for bringing that one in. And let me springboard off of that because, we talk about testicular cancer often being a young man's disease. And correct me if I'm wrong, but I'm guessing that at the end of the treatment, there are a lot of young men who are ready to be done with this and may not be as receptive as you might wish to talking about survivorship. And yet, a few years later, a decade later, may want to engage in that process more. And if that's a correct assumption, how do you help somebody just know that door is open later on down the road?
Yeah, I tell them up front. It's, we kind of have this defined, and this is with many cancers, after treatment, we want to follow you for X number of years. So for testis cancer, the defined surveillance is 5 years. When we get to that 5-year point, my patients usually end up in 3 buckets. So one is either they want to keep seeing me at least annually, even if we're not doing any diagnostics, Or they say, I don't want to come once a year, but maybe every 2 years, just so we have that connection. And there are some people who never want to come back to the cancer center ever again. None of those things is the wrong thing. But I always tell them, especially as our visits are being spanned out and we're seeing each other, less frequently, that they can experience these different kind of psychological changes over time. And the door is always open, right? Even if they decide not to do formal follow-up after 5 years, I will always have that connection with them, and they're always welcome to reach out to me. I hope that helps.
Yeah, thank you so much.
Of course.
Here's another question. What kind of response would you give if a patient states, my girlfriend is scared to have sex because she thinks she might get cervical cancer?
I've actually never gotten that question before. So patients who are actively undergoing chemotherapy, we encourage them not to engage in sexual activity during chemotherapy for a couple of reasons. There's concern about transfer in the semen, if their counts are low, that kind of stuff. But they will not give their female partners cervical cancer. So just offering reassurance that that's not something that will happen. Thank you for that question.
Absolutely. And then one more, and going back to the cryotherapy boots and gloves, and someone was wondering, would this be considered a palliative treatment?
I don't know that much about the boots and gloves. I mean, I guess anything we're doing in a supportive care context could be considered a palliative treatment. But yeah, no, I need to learn more about that.
Well, we are, so we're going to ask you to keep an eye on the announcements for the upcoming lectures, because I'm very excited that topic has made it onto our list for 2022, along with a lot of other great topics. So stay tuned for more about that. At this point, we're at 1 o'clock. And so let me just mention a few other things here. I'll keep an eye out in case any last minute questions come in. But I want to thank you, Mary Dunn. This has been amazing. Thank you so much. I want to thank the people of North Carolina for funding the University Cancer Research Fund and the UNC Lineberger Cancer Network. And as a result of that, our team, Mary King, Veneranda Obore, John Powell, Oliver Marth, Jason Paler, and Andrew Dodgson. None of this would be possible without all of their hard work.